But if I lay down and I play dead and I stay dead, maybe you'll get sick of being the monster out of my head, under my bed. Think you're something out of my nightmares, standing right there. But if I lay down and I play dead and I stay dead, then will you get bored of killing me?
Silhouettes of you are like a taunt. Never really know just what you want. With you I don't ever feel calm. I can feel the sweat inside my palms. Play with me like cats and a string. You don't understand the pain it brings. You don't ever wanna give me wings. You don't ever wanna set me free. You know I'm addicted to you, and it's twisted, you've been gifted with the evil voodoo. Got me coming back for more, even when I've been screwed. Dolls full of pins, pierce my heart straight through. I got issues in my head, I like you in my bed, but you keep me on red. Oh, everything is like a test, I better not text or I'll come off desperate.
But if I lay down and I play dead and I stay dead, baby you'll get sick of being the monster out of my head, under my bed. Think you're something out of my nightmares, standing right there. But if I lay down and I play dead and I stay dead, then will you get bored of killing me?
So if I play dead, will you regret everything that you did, that you said? I don't think you understand what you're doing, and my heart's black and blue from the bruising. I feel like when I'm with you I'm losing. I feel like you think that this amusing, sitting there gaslighting and confusing. Was it me? Is it me? Am I deluded? I'm the one who's always sorry, the conclusion, even though I offer all of the solutions. I wish you loved me like I love you, it's stupid. When I'm alone with you I never feel lucid. I wish I wasn't struck by Cupid. I wish when I first saw you I knew this. When I'm with you I feel so useless, I feel diluted, my heart's been wounded. Silhouettes of you are like a taunt. Never really know just what you want. With you I don't ever feel calm. I can feel the sweat inside my palms. Play with me like cats and a string. You don't understand the pain it brings. You don't ever wanna give me wings. You don't ever wanna set me free.
But if I lay down and I play dead and I stay dead, baby you'll get sick of being the monster out of my head, under my bed. Think you're something out of my nightmares, standing right there. But if I lay down and I play dead and I stay dead, then will you get bored of killing me? Then will you get bored of killing me? And will you get bored of killing me? And will you get bored of killing me? And will you get bored of killing me? told your friend you're not okay, and tell me what's wrong and why you never said you felt that way. And guess you're trying to stay strong and fake a smile until I look away. But I've known you too long, it hurts to watch your blue eyes fade to gray as you fade away, as you fade away.
Yeah, I'm about to fade away, cause every time I wake up I feel like it's Monday. Something's going wrong with all the chemicals up in my brain. All of a sudden I don't look at anything the same way. Got a buildup of my thoughts sitting in an ashtray. I'm sorry that I'm so inconvenient, okay. Just let me be me and I'll stay out of your way. I can see the way you look at me, I'm such a disgrace. I never really asked to be brought into this place. You wanna love me? Well then baby, have a taste. All the highs and the lows, no, you'll never be the same. I don't really wanna hurt you, but I can't control the pain. If you're sticking by my side, maybe we could be okay. Okay, maybe you could be the change I need today. I promise that I've never felt this way. I really hope that you will choose to stay through all the pain.
I know you told your friend you're not okay, and tell me what's wrong and why you never said you felt that way. And guess you're trying to stay strong and fake a smile until I look away. But I've known you too long, it hurts to watch your blue eyes fade to gray as you fade away, as you fade away, as you fade away. Try to stay strong and fake a smile until I look away. But I've known you too long, it hurts to watch your blue eyes fade to gray.
Lactulose, which acidifies the colon, will prevent the absorption of anything that is alkaline in nature, okay, like your ammonia. So therefore, a common side effect of lactulose is diarrhea, and it diminishes the absorption of ammonia, thereby improving the patient's condition. So, having that in mind, is it A, increased effects of alcohol to the body, B, increased excretion of potassium, C, enhanced glucose utilization, or D, decreased ammonia absorption? And the answer definitely is to decrease ammonia absorption. Okay, so now here are my pointers or tips for everyone who are taking the test in the coming months. Okay, now when you talk of classification, you have to focus on these drugs. First and foremost, diazepam or Valium, it's a minor tranquilizer, it's an anti-anxiety, it's a benzodiazepine derivative. What we need to remember about diazepam, diazepam should not be given in clients with myasthenia gravis. It worsens respiratory depression. However, there are literatures that say it could be used to manage the rigidity of muscles in patients with multiple sclerosis. So if you meet a concept that would tell you which drug can be given in multiple sclerosis that may worsen respiratory depression in myasthenia gravis, and that's going to be diazepam. Now, one important thing also that you have to remember about diazepam is that it causes the 3Ds, dizziness, drowsiness, dry mouth, which increases the risk of the patient for falls. So it's very, very important that you have to raise the bedside rails and make sure that the call bell is within the patient's reach if they need to go to the bathroom if they have taken the medication. You don't give diazepam with alcohol. It increases the depressant effect of the drug. You don't give diazepam with caffeine-containing foods, as it counteracts the effect of diazepam, leading now to the paradoxical reaction. Now, pay particular attention also to the fact that NCLEX would not just ask you about those basic things. NCLEX would even ask you about interaction of diazepam with herbal remedies like kava and valerian. Remember that kava and valerian are both sedatives. So you should not be giving it to patients who are taking diazepam or any benzodiazepine for that matter, like your oxazepam or lorazepam. Okay, so let's now move on to and always remember, before I forget, diazepam or Valium is incompatible with any drug, so it has to be administered using a separate syringe. Now, atropine is also one of the mainstays of those things that you would usually find in a lot of test preparations guidebook. And I am not surprised if you're going to meet this question when you engage in your test. Okay, so atropine is a vagolytic agent. So as a vagolytic agent, it interferes with vagal impulses. So what does it do? It increases the heart rate. Therefore, it is given in patients with AV block or bradycardia. However, it may potentially worsen atrial fibrillation. So pay particular attention to the fact also that optic drugs, okay, the optic version of atropine is usually given or instilled in both eyes of the patient before eye examination. Okay? However, you have to note whether the patient has glaucoma or not, because if the patient has a glaucoma, definitely pupillary dilatation could increase the intraocular pressure, which contraindicates the use of atropine. Okay? So atropine could also be given before procedures or surgical interventions to decrease salivation to prevent aspiration. Okay, now, fludrocortisone or Florinef is usually used in patients with Addison's disease, okay, to stabilize the patient's blood pressure. Now, what is the most important thing that you have to remember about fludrocortisone when you're about to take the test? Take note that patients with Addison's disease can be at risk for Addisonian crisis. And what is considered as the primary risk factor for Addisonian crisis gonna be stress. Okay, now what are the common causes of stress? You wouldn't believe it, but a survey said getting married, staying married, but you cannot, unmarry from your partner when you're taking fludrocortisone. So the best thing to do is to ensure that you're always taking fludrocortisone, especially if you are supposed to engage in a stress provoking situation like a visit to the dentist. So if a patient has Addison's disease and the patient's taking fludrocortisone, you have to remind them to take their medication before they visit their dentist. So at this point in time, Are you all right with our approach so far? Am I moving too fast? Please do tell me through our chat box. Okay, do you like what we are doing so that I know how to adjust for everybody's comfort? Okay, so Maribeth says ready. Okay, thank you very much for the thumbs up from Jessica. Okay, from April Monsanto. Okay, and of course from Maribeth. Okay, we're okay so far, says Rose Bondoc. Thank you so much for that feedback. Let's move on now to our next part of our framework. Okay, here we go. The second part of our check framework is that you have to know how do you measure the effect of medications. For example, if the patient's taking an antidepressant that works after 2 to 3 weeks for the initial therapeutic effects and 3 to 4 weeks for the full therapeutic effects. So how would you know that the antidepressant is working? You have two parameters. You have adequate sleep and increased appetite. But you have to learn how to operationalize those things in terms of how the patient would tell you about the improvement in their sleep and the improvement in their appetite. So if they ask additional snack of cookies and juices, that means there's increased appetite. But if they are sleeping 12 to 14 hours, that's a sign of oversedation and may not reflect the desired effect of the drug. So in essence, you have to know how to evaluate how the drug is affecting the patient's condition. So here we go. A patient who is taking haloperidol, which is a major tranquilizer, is being given benztropine mesylate in order to prevent pseudoparkinsonism. The nurse evaluates that benztropine mesylate is beginning to exert its therapeutic effect when there is. So here we go. Haloperidol is typical antipsychotic. So it decreases the positive symptoms of schizophrenia. It's a major tranquilizer. The adverse effect would be pseudoparkinsonism. Now, how do you diminish pseudoparkinsonism? Then you have to administer anti-Parkinsonian agents like benztropine mesylate, which exerts the therapeutic effects within 2 to 3 days. So the question is, how would you know that it's effective? Definitely if it reverses the signs and symptoms of pseudoparkinsonism. So let's pay particular attention now to the options. Is it A, diarrhea, B, decreased fine hand tremors, C, decreased muscle spasticity, and D, tongue twitching? Definitely tongue twitching or lip smacking is indicative of tardive dyskinesia, which is potentially irreversible in patients who are taking major tranquilizers. So that's not the answer. So your major tranquilizers would usually cause anticholinergic side effects like constipation. So diarrhea, letter A, is not the answer. We're left with B and C. Okay, now you could be remembering that your patient having pseudoparkinsonism could be manifesting tremors, but you have to be specific and you have to learn how to differentiate the types of tremors in a patient. Okay, if you're preparing for the NCLEX, like for example, asterixis or flapping tremors is found in patients with hepatic encephalopathy or in patients with renal failure. Intentional tremors could be found in multiple sclerosis. Resting tremors could be found in patients with Parkinson's disease. So fine hand tremors could be found in patients with hyperthyroidism, and it's a side effect of lithium. Coarse hand tremors is found in patients with alcohol withdrawal syndrome, like delirium tremens, and it could also mean neurotoxicity in a patient who's taking lithium. Therefore, details such as what kind of tremors do you need to evaluate is very, very important. So you have to learn how to study specific concepts for the test if you're aspiring to pass the NCLEX RN. Therefore, letter B is not correct because fine hand tremors is not found in a patient with pseudoparkinsonism. So you cannot use it as a parameter of evaluation of the effectiveness of the drug. Therefore, the best answer is C, decreased muscle spasticity. Okay, now, what are my pointers that I'd like to highlight related to this important aspect of our framework? So let's begin. This moprisine, okay, is a medication that is usually used as a treatment for patients with diabetes insipidus. It's a synthetic antidiuretic hormone. Now, it's also used as treatment for patients with bleeding disorders like hemophilia or von Willebrand's disease because the version, like estimate, that is given to those patients with hemophilia and von Willebrand's disease would increase the secretion of your clotting factors. Okay? Now, for desmopressin, how do you evaluate the effect? So, in diabetes insipidus, the patient would usually have polyuria together with a decrease in the urine-specific gravity below 1.005. We all know for a fact that the normal urine-specific gravity is 1.010 to 1.025. So what does that tell us? So your desmopressin will reverse those two things. So first, in diabetes insipidus, the patient will have polyuria. In fact, they could have as much as 21 liters of urine per day. So which means desmopressin will decrease urine output, and as I told you a while back, your diabetes insipidus is characterized by decreased specific gravity less than 1.005. So your desmopressin will normalize the specific gravity. So how would you know that desmopressin is effective? When there's decreased urine output and when there's normal specific gravity of the urine. Now take note that desmopressin is given intranasally, so you have to use one nostril at a time, because here's the most important thing that you need to remember: it can potentially cause nasal irritation. And of course, if the patient is having runny nose, that's something that you have to refer to the physician, because this medication may not be properly absorbed if the patient's having runny nose. Okay? Now, epioatin alpha or Epogen is given in order to stimulate the bone marrow to produce red blood cells. Now, this is also used as a treatment for patients with aplastic anemia. It's used for patients with renal failure who develop anemia. Okay, so what do you need to check here? You need to check the red blood cells. So the patient could have complete blood count laboratory exams when they are taking your Epogen. Next, if Epogen increases the RBC, filgrastim or Neupogen increases the WBC of the patient. Now, this is indicated for patients with neutropenia. You have to know for a fact that patients with neutropenia could be immunocompromised, which simply means that the patient could be at risk for infection. So if the patient has neutropenia, you don't bring anything that's fresh in the room. So no fresh flowers, no fresh fruits, okay, no fresh foods, only well-cooked snacks could be given to the patient. So filgrastim again increases WBC, Epogen increases RBC. Now, bumetanide is a diuretic. So this medication is usually used as a form of treatment for patients with ascites, especially if they are having liver failure, okay, or liver cirrhosis. Now, how do you evaluate the effect of Bumex? You have to check the urine output. If the urine output is increased, okay, higher than normal, then the medication is exerting its therapeutic effects. Okay, so how are we moving on so far? Are you able to cope with our discussion? Okay, thank you very much, VJ Mendoza, for saying okay, Sir Ray. Thank you. Valerie, thank you for the thumbs up sign. And of course, okay, Merlin Mendoza, Van Mercado, a lot of them already are giving the thumbs up sign. Okay, so thank you very much. Okay, at this point, colleagues, are you learning? Okay. Is it worth your time being here in our teaching and learning session today? Excellent. So let's move on. The third part of our framework. Okay. Here we go. The exact time of administration of certain drugs. So here's an example. An alcoholic patient in the rehabilitation ward was started on antabuse. But I have to tell you, colleagues, that antabuse since 2020 has been considered as obsolete because we have more newly formulated drugs for patients with problems related to chronic alcoholism like acamprosate calcium. Okay, so your antabuse could cause the antabuse alcohol reaction, which begins with facial flushing, then persistent nausea and vomiting, and which could progress to respiratory depression. That's why it's very important that if your patient is taking antabuse, they have to remain alcohol-free for at least 12 hours before taking the first dose. That would mean telling our patient to avoid anything that's alcohol-based. And our code is MOFABs. M would be mouthwash. O, over-the-counter cold remedies like elixir terpene hydrate. F, fruit-flavored extracts. Okay. F, food sauces with alcohol. A, aftershave. V, vinegar. And S, skin products. Okay, so any of these, even if it's just inhaled by the patient who's taking antabuse, could trigger the antabuse alcohol reaction. Therefore, okay, the answer to this question is it A, before meals, B, after meals, C, after the patient remains alcohol-free for at least 12 hours, and D, immediately upon admission regardless of alcohol consumption. May I check on everyone if you are listening? What's the answer based on our discussion? Could you please type it on our chat box? Go! And there they go, Jenny, Diana, Van, Louie, Roxanne, everyone, they are learning fast. After the patient remains alcohol-free for at least 12 hours. If only for that, I wish you well in your exam. So let's move on. Now, what are my tips or pointers which you may want to remember before taking your test? Let's begin, okay? Ibuprofen, I told you about this a while back, that you have to remember it's best taken with meals. Now, methylphenidate could be given two ways. But the most important thing to note about methylphenidate or Ritalin is that it is a stimulant and it may potentially cause insomnia. So it's best taken in the morning, at midday, or at least 6 hours before bedtime, or not beyond 2 p.m. Okay? And usually, your Ritalin is not indicated for children below 6 years old. Now, pay particular attention to this fact now. Your Ritalin can be given before breakfast, okay? Or if the patient experiences GI irritation, it can be given after breakfast. You don't choose after meals, because if you say after meals, that includes the dinner time, which is inappropriate because your stimulant should not be given after dinner. Okay, now two things to remember about methylphenidate. It alters eating and sleeping. Therefore, if you have a question that goes this way, which of the following patient is most at risk for altered growth and development? We know for a fact that sleeping and eating are associated with the child's growth and development. So anything that alters eating and sleeping may alter growth and development. So the answer would be a patient diagnosed with attention deficit hyperactivity disorder that's taking Ritalin. Okay, that's the way how you analyze things. You don't just memorize facts. You don't just read it at face value. You have to learn how to use it to address patient issues if you are studying and you want to pass your test. And of course, your disulfiram, we learned a while back that it should be taken, the patient should be alcohol-free for at least 12 hours before taking the first dose to prevent the antabuse alcohol reaction, which progresses from facial flushing, persistent nausea and vomiting, and then eventually to respiratory depression. Okay, so let's now move on. So what about patient teaching tips, okay, or client teaching tips? What do we need to remember about this? Here's an example. The nurse would include which of the following in a teaching plan for a patient receiving iron supplements? This is easy. If this comes out in your test, it could be that you got the answer to the previous question incorrect, because this is one of the easiest. Now, iron supplements are best absorbed in an acidic environment, so it has to be given before meals. Now, to facilitate its absorption, you have to give it with an acidic fluid like an orange juice to facilitate the absorption. Now, it takes approximately 3 to 4 weeks before initial therapeutic effects of iron becomes evident, so which simply means if the patient's just taking the iron for 1 week, they will have yet to experience any positive effect of the supplementation. Now remember, we also need to tell our patients that iron can cause constipation. Their stools could turn black, but this is not a cause for alarm, as it is an expected side effect. Okay, now if iron is given in liquid form like iron dextran, it should be given in Zaytrac method of administration. So if you're giving it through Zaytrac, you have to remember that Zatrac still requires aspirating. Okay? Aspiration before injection. The regular IM, we no longer aspirate, as it has been found by recent evidence that the sites that we use for intramuscular injections do not contain large blood vessels that could be potentially hit. Okay. However, okay, you have to know that if your iron is being given in liquid form and it's being given through Zatrac, you have to stretch the skin laterally, then inject the needle, make sure that the needle stays for 10 seconds. Then after that, remove the needle, and you are not required to massage the site. Okay? That could potentially discolor the skin. So, having those concepts in mind, let's answer the questions. Take it with milk or antacid to decrease GI problems? No, this is not the proper way of taking this medication, as it could potentially decrease the absorption. It should always be taken on an empty stomach. We can consider that. Take it with orange juice. Okay. Now, what is wrong with letter B here, or letter D? Crackers will help decrease gastric irritation. You have the word always. If the patient is taking iron and GI irritation occurs, the patient can take the medication after meal. So, saying that it should always be taken on an empty stomach is not correct. So, the best answer is take it with orange juice to facilitate the absorption. Wow, Arlene and Isa, congratulations. Okay, you did well. You answered the question correctly. Okay, a round of applause for you. Now, what are now the medications that I would like you to remember when you are talking about this part of our framework? So, what medications would require you to remember some instructions? Here we go. Alendronate or Fosamax. Now, alendronate is given as a form of treatment to patients with osteoporosis. Take note, even the liquid that you take it with could affect its absorption. You never give it with mineral water, because mineral water decreases the absorption of alendronate by 10%. So it's best to give it with plain water or distilled water. Next, you don't take alendronate if you cannot sit up or remain standing for 30 minutes to an hour after taking the medication, because it could potentially cause esophageal irritation. Therefore, what activity could be appropriate for a patient who's taking alendronate? Reading the newspaper or reading books, because that would allow them to sit up, okay, immediately after taking the drug. Okay, now, it's also important for you to note that you need a referral to the dentist if your patient's taking alendronate. Why is that so? Because it has the potential to erode the teeth, okay? So, the patient needs to be referred to a dentist before therapy or treatment with alendronate starts. And of course, you have your cyclosporine or Sandimmune. This is an anti-organ rejection medication. So it's given as a prophylaxis to prevent organ rejection in a patient who has received, for example, a donated kidney, or the patient has received other organs which have been donated. So, now, two things that I'd like to highlight related to cyclosporine. One, it should not be given with grapefruit juice, because your grapefruit juice alters the metabolism of the medication. In essence, it decreases the utilization of the medication and may potentially increase the serum level. Okay? So, second important thing about cyclosporine is the fact that you have to protect the patient from infection. Okay, so those are the things that I'd like to highlight. Next, levodopa is given in patients with Parkinson's disease, and levodopa should be given with vitamin B6. But once again, we have to operationalize vitamin B6. Your vitamin B6 are found in protein-rich. It's given in patients with, it's avoided rather in patients who are taking levodopa. So which means instruct the patient to avoid foods that are high in vitamin B6. Okay, and vitamin B6 is found in protein-rich foods. Therefore, you would notice that chicken is high in protein. If you allow a patient who's taking levodopa to have a piece of chicken for dinner, the signs and symptoms of Parkinson's disease will worsen, because protein decreases the absorption of levodopa. Okay? Now, vitamin B6 also diminishes the absorption of levodopa. So, if you are asked a question, what diet is usually given to patients who are taking levodopa, then the answer should be low protein or avoid meat. Okay? So those are the things that I'd like you to remember related to your alendronate, cyclosporine, and levodopa. Now, another important instruction that you may want to focus on would be the number 5 in our framework. Okay? And this is keys to safety. Okay? Here's an example. When administering lithium, the nurse should ensure that the patient have a diet consisting of. Now remember, lithium is a salt, but it's a type of salt that needs to combine with sodium, and it needs to be diluted in water for it to be exclusively excreted by the kidneys. So what does that mean? Lithium, okay, in itself cannot be simply absorbed. It needs to be given with sodium and fluids. That's why you need a high sodium, high fluids diet. When you say high sodium, it could be 3 to even 6 or 10 grams of sodium per day. And then high fluids would be 3 liters of fluids per day. Okay? So the best answer to this question is letter C, 6 grams of sodium and 3 liters of fluids. Okay. Now, what are the things that we have to note? The interactions for patients with who are taking lithium. Okay, interactions for patients who are taking this drugs. First and foremost, your sildenafil or Viagra. Okay, pay particular attention to this. This is given to patients with erectile dysfunction. It should not be given to patients who are taking nitroglycerin or isosorbide mononitrate or isosorbide dinitrate or your nitrates, because combining sildenafil with nitrates could lead to fatal hypotension. Okay, piroxicam or Fildin is a non-steroidal anti-inflammatory agent. It's very important to focus on these things because your piroxicam, focus on these two, could potentially cause bronchospasm. So if a patient who has taken aspirin eventually would take piroxicam and they have had bronchospasm episodes when they're taking aspirin, that's a cause for concern. And then your Fildin may also worsen bleeding. Okay. Your cisplatin is given as a treatment for patients with cancer. So it's a chemotherapeutic agent. Now, it is nephrotoxic. So if it is nephrotoxic, you cannot administer it if a patient's also receiving another nephrotoxic agent like your aminoglycoside, streptomycin, or neomycin. That could potentially result to acute kidney injury. And of course, your spironolactone or aldactone is a potassium-sparing diuretic. You cannot give it if the patient's having hyperkalemia or if the patient has tall peak T waves in the EKG, because that indicates hyperkalemia. Okay. So, which drugs do we really need to study? Are you ready? We are just done with our framework. Are you ready to know which drugs do you need to study? Those of you who are taking the test next month. Now remember, a copy of my presentation will be sent to your email after our webinar. Okay? So I think that deserves a round of applause from everybody. You are going to receive a copy of my presentation. Yeah. And that's going to be for free. Okay, here we go. Which drugs do we need to study? Okay. So, top 5 answers on our chart. Services. Mannitol. Okay. Which aspect of mannitol do you want to study? Do you need rather to study and learn before you sit for your test? Okay, remember class, it's not just about the drug mannitol per se. You have to know as a nurse what is your role. How do you give the medication? So you have to give mannitol using a filter because the solution can crystallize. So at 1.5 to 2 grams per kilogram of body weight over 30 to 60 minutes, that's how it should be given. It should be over 30 to 60 minutes, and it should be warmed before administration to redissolve crystals, and then cooled to body temperature immediately before administering it. Now, if the mannitol is kept in a solution below 20 degrees centigrade, it can crystallize. So there's gonna be a problem on that, okay, if it crystallizes. That's why you need a filter, especially if you're giving higher concentration mannitol, like mannitol 25%, okay? So store mannitol at a room temperature of between 20 to 30 degrees centigrade. Now, let's summarize. Now, this is coming from my book. Okay, so mannitol is, let's check, mannitol is a diuretic. It's also used to treat cerebral edema. So how will you know that it's effective? You have increased urine output. Exactly what time do you have to give it? Best given in the morning to prevent nocturia. Client teaching tips: avoid alcohol and prolong exposure to sunlight. Keys to giving it safely: monitor the BP and serum potassium levels. Your mannitol could cause hypokalemia, and it can also cause rebound intracranial hypertension, so monitor the pulse pressure. Having that in mind, let's take a look at a sample question, which I know everybody would love to see, especially those who are about to take their test. I'm giving you fair warning. Remember this question. Don't forget, I discussed it with all of you. Okay, for a client receiving 25% mannitol, the nurse should carry out the following intervention. Select all that apply. Use an administration set with a filter. We put a check. Monitor potassium levels. Yes. Cool the solution to body temperature before infusion. Yes. Warm the container to dissolve crystals. Yes. Store the solution at a temperature below 20 degrees. No. That could cause crystallization. Class, is that clear enough for you to remember the concepts I'd like you to remember for your test? Tell me, yes or no? Come on. Thank you, Louie. Okay, thank you, Danica. Thank you, Ferulin. Learning so far. Here we go. Number 4, services. Okay, lithium. Now, a lot of concepts about lithium. Question, what do we need to remember? I'll give you a fair warning. Remember the side effects, and you have to learn how to differentiate it from toxic effects. Why? Because sometimes there is a very thin line between the side effects and the adverse effects, and I'll discuss that in a while. Here we go. Let's begin with a functional concept. Lithium was discovered by Johann Arfvedson in 1817, and you may not believe it, it was initially used as a salt substitute for patients with congestive heart failures. Then eventually, they discovered the antimonic properties of lithium. Okay? Now, what is difficult with this treatment is the fact that the therapeutic levels is so close to the toxic levels. So the priority for these patients, therefore, is for the nurse to monitor the serum levels of lithium. Now, if you are asked, what is the therapeutic level of lithium? Then you say it depends. Because we have a different therapeutic level if the patient is 65-year-old and below. And there is a different therapeutic level if the patient is above 65 years old. Okay? So, pay particular attention now. We also have a difference in terms of the lithium level during the acute phase of treatment, which is within the first 3 months of administering lithium, and the maintenance phase of treatment, which occurs after the first 3 months. So, for a patient below 65 years old, here's a chart. The therapeutic acute dose is 0.5 to 1.5 milliequivalent per liter, and the maintenance dose is 0.5 to 1.2 milliequivalent per liter. Now, pay particular attention that your acute dose is higher than your maintenance dose. And the initial lithium level monitoring is usually taken a week after the patient's onset of treatment, which simply means that a week after the onset of treatment, blood is collected. And when is it collected? 12 hours after the patient's last dose or early morning before breakfast, to check on the lithium levels of the patient. If it is within 0.5 to 1.5, that's normal. Just continue to monitor the serum levels. Now, after 3 months, we are now on the maintenance phase of treatment. The therapeutic level of lithium should be 0.5 to 1.2, which goes on to say that if you have a question on lithium level monitoring, check on whether the patient is in the acute phase of treatment or maintenance phase of treatment, because the level for it to be considered as therapeutic differs when the patient is in the acute phase or the maintenance phase of treatment. Let's move on to patients who are elderly, okay? So 65 years old and above, acute dose therapeutic level 0.6 to 1.0, maintenance dose 0.4 to 0.8 milliequivalent per liter. Now, let me tell you this. Why do we have a lower level of therapeutic range for the elderly patient? Because they have poor renal excretion. So they may not be able to excrete lithium if it is given at higher doses. Therefore, remember a functional concept for the elderly patient, 65 years old and above, the lithium level should not exceed 1.0. Okay? Okay, now, what happens if there is increased levels of lithium? The side effects may worsen. So nausea, vomiting becomes persistent nausea, vomiting. Okay? Tremors progresses from fine to coarse tremors. Okay? Now, what are our interventions? It depends on the level of lithium. If you have 2.0 to 2.9, this is mild to moderate lithium toxicity, increase fluids, and then usually the patient will have to undergo hemodialysis. Okay? Now, if the lithium level reaches 3.0 and above, this now could lead to possible neurotoxicity. The patient could have signs and symptoms of like dysarthria, dementia, okay, seizures, coma, and even cardiac arrest. So you will have to implement emergency intervention. So what is essential therefore for the nurse is to pay particular attention on the different lithium levels. Remember, 2 to 2.9, mild to moderate, 3.0 and above, severe lithium levels. So mild to moderate lithium toxicity is manifested by note, colleagues, that the signs and symptoms of mild to moderate lithium toxicity are the same signs and symptoms that we have when a patient's having side effects like diarrhea, vomiting, tremors, muscle weakness, and then drowsiness. Okay? So it's the same. Okay? Now, what happens when the patient would suffer from mild lithium toxicity? Okay? If it is mild, it goes away. Okay? If you stop giving the lithium and you increase fluid intake. However, okay, if it doesn't and it worsens, then the patient's developing moderate lithium toxicity that is treated with stomach pumping, bowel irrigation, IV fluids, hemodialysis, and of course, close monitoring of the vital signs. Okay? Now, if the toxicity progresses to severe, meaning at level 3.0 and above, what happens? There will be increased temperature, so hyperthermia, seizures, slurred speech. So the patient's like having CVA, okay? So the patient would also have signs of dementia and dysarthria, meaning they are unable to use their muscles of speech articulation, leading to slurred speech, and then they will have rapid heartbeat and low blood pressure, okay? So let's summarize. This is for everyone's guidance. Okay. So here are the side effects. Fine tremors is a side effect. It's not a cause for alarm. However, when it becomes coarse tremors, then that's a toxic effect. So the fine tremors that progress to coarse tremors needs to be referred to the physician. Diarrhea and nausea and vomiting are side effects. When will this become toxic effects? When you have increasing diarrhea and vomiting. And then you have polyuria, polydipsia, edema. Okay? These are side effects. However, if the polydipsia and polyuria leads to renal failure, then that becomes a toxic effect. Then, vertigo is a side effect. So the patient would feel as if the room is spinning, as if the room is rotating, as if the room is revolving. However, if that progresses to ataxia, lack of coordination and loss of balance, those are toxic effects. Okay? Difficulty of concentrating is a side effect, but disorientation is a toxic effect. The presence of metallic taste is a side effect, but seizures and coma are toxic effects. Are we learning, class? Tell me through our chat box, yes or no. Okay, excellent. Thank you very much. Okay, so let's summarize everything once again. Coming from my book, okay, which 100 people will receive after the webinar. Anti-manic, it decreases hyperactivity. Now, how would you know that lithium is effective? Let's operationalize decreased hyperactivity. So if the patient is able to finish watching a 30-minute television show, that indicates diminished hyperactivity. It's best taken after meals to decrease GI irritation, increase fluid intake, and sodium intake. Avoid activities that increase perspiration, as this may affect the body's sodium levels. It takes 10 to 14 days before the therapeutic effects become evident. That's why usually lithium is given with an antipsychotic. What is the purpose of the antipsychotic? It manages the acute symptoms of mania until lithium takes effect. However, recent literatures now have suggested that lithium is an effective treatment for acute mania. It was believed before, because of the slow onset of action, that it may not be appropriate for acute manic patients, but recent evidence now suggests that it can be used for patients with acute mania. So an antipsychotic is administered during the first 2 weeks to manage the acute symptoms of mania until lithium takes effect. So monitor the serum levels. You have the adult dose, the adult maintenance dose, and of course for elderly patients above 65. Nausea, anorexia, vomiting, diarrhea, abdominal cramps, blurred vision, and confusion indicate lithium toxicity. Fine hand tremors may be associated with lithium side effects. If the fine hand tremors progress to coarse hand tremors, suspect neurotoxicity. Mannitol or Diamox is administered if toxicity occurs. Now, comprehensive enough? The information that you find in my book? How do you find it, class? How do you find it, colleagues? I think this would perfect. Thank you very much, Ferroline. That's why it's an essential thing nowadays to have this. And it says here original. So please do get a copy of the original. Amazing, easy to understand. Thank you, Gentrix. Okay, so let's move on. So let's try answering a sample question this time. Which of the following manifestations needs further evaluation from the nurse? If you see this, the phrase needs further evaluation, it simply means that the effects that we are looking at and evaluating, if being manifested by the patient, would require for us, RN, to report it to the physician because it means there could be toxicity. Okay? So, select all that apply. Fine hand tremors, this is a side effect. No need. Put an X. Excellent, Ferroline. Severe nausea and vomiting. Ang yabang na, mabilis na. Coarse hand tremors, yes. Confusion, yes. Seizures, excellent. Okay. And that's because of the information we have from my book, which it took me 3 years to write this book because I have to create something that would be valuable for those who are taking the NCLEX, okay? And if you need guidelines, okay, on which pages to study for your specific test within the coming months, please do send me an email and I will send you a note, okay? So, on our survey, the number 3 drug that you need to remember for your tests in the upcoming months would be services. Digoxin. Okay, digoxin is a cardiac glycoside. Now, it is given in patients with atrial fibrillation, but not in patients with ventricular fibrillation, as it could potentially worsen ventricular fibrillation. Okay, so pay particular attention now to the information, once again, culled from my book. Okay, it's a cardiac glycoside. It increases the force of cardiac contraction, but it decreases the heart rate. So for those of you who are studying for the test, remember that the minimum heart rate for adults would be 60. For full-term infants would be 90. For preterm infants would be 100. Okay, now if the patient is manifesting therapeutic effects of the drug, there should be normal heart rate in a patient with atrial fibrillation. There should be slowed or controlled heart rate. Okay, taken at the same time of the day with or without food, and it's usually taken in the morning after breakfast. Now, the most important thing that you have to pay particular attention to would be signs of toxicity like greenish or yellowish vision. Now, you wouldn't see medical terms on the test like xanthopsia, so stop memorizing medical terms. Remember, the test is very layman's. You have to operationalize your concepts. So when you say xanthopsia, how will the patients describe this? They would usually say, the TV doesn't look good to me. Okay? If that's the patient who is taking your digoxin, that could be digoxin toxicity. But if the patient's not taking digoxin and the patient says the TV doesn't look good to me, if that person, okay, is someone belonging to your race, you have to ask the person, check your cable bill. Especially here in the Philippines, a lot of people don't pay their cable bills on time, okay? Lack of appetite, how do you operationalize this? The patient would describe this as, I have not been eating as I used to. Okay, that could mean anorexia if your patient's taking digoxin. But if you have somebody who just says, I've not been eating as much as I used to, well, that could be related to poverty brought about by the pandemic. And of course, the presence of vomiting, diarrhea, irregular pulse, and confusion. Pay particular attention to the fact that if your patient's taking digoxin and the patient exhibits anorexia and vomiting and you still gave the next dose despite that, you'll be held accountable for malpractice because you failed to recognize that the patient is now manifesting signs of toxicity. Once again, keys to giving it safely: assess the patient's heart rate as it causes bradycardia. If the heart rate of an adult is below 60, reassess in 5 minutes. If it's still below 60, refer to the healthcare provider. Withhold dose and notify the healthcare professional if the pulse rate is below 70 beats per minute in a child or below 90 beats per minute in an infant. Monitor the serum potassium levels as decreased potassium manifested in the presence of the pathologic U wave in the EKG tracing could trigger arrhythmia if the patient's taking digoxin. And keep the antidote, digoxin immune fab or digibind, accessible, ideally at the patient's bedside. So using the concepts which we just learned, let's try to answer a sample question. A client who's taking digoxin makes the following statements. Which one should the nurse evaluate further? 1, my heart contraction seems stronger. 2, I take my medication after eating breakfast. 3, I have not been eating as much as I used to. Or 4, my eyesight has not changed a bit. So the answer, I have not been eating as much as I used to. That is anorexia. Way to go! Everyone is enjoying participating in answering questions that I'm posting. Excellent. Okay, so let's move on now to number 2 in the survey. Survey says acetaminophen. Now, acetaminophen toxicity is the most common cause of fulminant liver failure. Okay, since fulminant liver failure is associated with an overdose of acetaminophen, like Tylenol. Okay, therefore, the initial treatment would be to administer the antidote of acetaminophen, which is acetylcysteine. Okay, now let's try to differentiate acetaminophen versus ibuprofen. Okay, so both medications, acetaminophen and ibuprofen, would usually be given for fever and pain. So for example, if the patient is having low-grade fever or the patient is having pain related to menstruation, okay, they can take any of these medications. Now remember, your acetaminophen is primarily an analgesic and you have to keep watch of the patient's liver enzymes, specifically your ALT and AST. Ibuprofen, on the other hand, is a non-steroidal anti-inflammatory agent. So in addition to relieving fever and pain, your ibuprofen has a better action in relieving inflammation. So even if your acetaminophen can relieve the pain in arthritis, it's ibuprofen that would usually decrease the inflammation. So acetaminophen and ibuprofen both can decrease fever and pain, but ibuprofen has an added effect of relieving inflammation. Now, if acetaminophen is hepatotoxic, ibuprofen is nephrotoxic. So, if the patient has any kidney problem, pay particular attention. You have to refer the administration of ibuprofen to the healthcare provider. And take note, ibuprofen is best given with meals. Okay? So once again, let's summarize acetaminophen. From the information I have in my book, it's an analgesic, so therefore it decreases pain. Antipyretic, it diminishes fever. So how will you know that it's effective? Relief from pain and fever. Take it with food. If GI upset is noted, it can cause hepatotoxicity, so refer if jaundice develops. Keep the antidote acetylcysteine at the bedside and then assess for possible allergy. On the other hand, ibuprofen is a non-steroidal anti-inflammatory agent. It's usually given in the treatment of osteoarthritis and rheumatoid arthritis because it has a stronger anti-inflammatory effect. So how will you know that it's effective? Relief from pain. It's best taken with meals, and take note, it may potentially cause GI bleeding and blood dyscrasia. So report ringing or roaring in the ears. That's tinnitus, which may indicate toxicity. Manifestations of kidney damage like changes in urinary pattern increased weight, edema, increased pain in the joints, fever, blood in the urine, which may indicate bleeding. Then, to prevent photosensitivity, instruct the client to use sunscreen and avoid concurrent use with aspirin or piroxicam and other NSAIDs, as this may precipitate GI bleeding. Okay. So, with those information, let's try answering a question. Here is a question on fulminant liver failure. A patient being treated for fulminant liver failure has the following doctor's order. Okay. Which doctor's order should the nurse question? Here we go. So, let's take a look at the doctor's order. Obtain PTT and PT. Serum creatinine level, acetaminophen for pain, IV fluids, prepare for possible liver transplant. The answer definitely is your acetaminophen, which could worsen, okay, the weakened liver. Okay, so the pain medication. So this is one of the types of the questions that you need to be familiar with. It's called chart exhibit. Okay, and of course, the number one in our survey. Survey says, here we go. What do you think? Now, for this medication, I created 3 separate videos on our YouTube channel, which you may want to go over. And this is related to insulin, okay, which is given in clients with diabetes, okay, to decrease serum sugar levels. Okay, so insulin Lispro or Humalog, it's an anti-diabetic agent. How will you know that it's effective? When your blood sugar level normalizes, it's best taken 15 minutes before a meal. The onset of action is usually less than 15 minutes or 5 minutes, 10 minutes, for as long as it's less than 15 minutes. It's very rapid acting. Keep the insulin in the refrigerator. So how do we mix 2 types of insulin? For example, regular insulin and intermediate acting insulin. So first, remember the code IRRI. So you begin with intermediate acting, okay, intermediate acting, then rapid acting, then intermediate acting. So first and foremost, okay, inject air into the regular or rapid acting, and then withdraw the needle and change the needle, inject air into the NPH insulin, then aspirate the regular acting insulin, withdraw the needle, and then aspirate the NPH insulin. Okay? So first, inject air, IRRI. Okay? So regular, okay? Then regular, intermediate. So IRRI. Okay, that's the way to remember it. So Lantus and Levemir. Lantus is a low-acting insulin. It cannot be mixed with other types of insulin and other drugs. Okay, so let's try answering a question based on that set of concepts that we discussed. So a nurse is preparing to administer regular and intermediate acting insulin in one syringe. Let's do drag and drop. So what do? Inject air to the intermediate acting insulin first. Okay, so that's a I. And then inject air into the regular insulin, IR. Then aspirate the regular insulin. Then aspirate the intermediate acting insulin, IRRI. Okay, so let's summarize. To put everything into perspective, this is a set of pointers I'd like you to remember, colleagues. An adverse effect needs to be reported to the healthcare provider. So, sore throat in a patient who is taking antipsychotics could indicate a granulocytosis, which is a medical emergency, so you need to refer it immediately. High blood pressure in a patient taking methyl ergonovin maleate may indicate uterine hypertonicity, so you have to refer it immediately to the healthcare provider. The presence of rash or allergic reaction from antibiotics, even from anticonvulsants like lamotrigine or dilantin, the presence of measles-like rash could mean allergic reaction or the development of Stevens-Johnson syndrome. So you have to refer it immediately. Impotence is an adverse effect of antidepressants and antihypertensives if taken for a long period of time. Muscle weakness may indicate hypokalemia if the patient is taking laxatives and diuretics. And then decreased pulse rate is an adverse effect of cardiac glycosides. Oliguria is an adverse effect of aminoglycosides because these medications are nephrotoxic. You have to remember you need to check the peak and true levels. Peak level is usually checked 15 minutes to 30 minutes after the third or the fourth dose for medications administered IV, and 30 minutes to 1 hour for medications administered IM. And for the true levels, it should be checked 30 minutes before the next dose. Nose bleeding could be an adverse effect of anticoagulants like warfarin, dabigatran, or heparin, enoxaparin. Okay. Fever above 38.5 may indicate malignant hyperthermia, and this is usually common in patients who are taking quetiapine or Seroquel, which is an antipsychotic. Increased ALT and AST indicates hepatotoxicity, an adverse effect of anti-TB and antipsychotics. Ringing in the ears could mean tinnitus. So adverse effect of aspirin, synchronism, adverse effect of quinidine. Now, ringing in the ears is also present in synchronism. In synchronism, you have blurring of vision, tinnitus, and then the patient will have CNS symptoms like fever, headache, tremors, dizziness. That could sometimes even progress to signs of psychosis like delusions and hallucinations. So this is associated with those who are taking quinidine. So synchronism usually occurs in patients taking quinidine. Then edema of the fingers is an adverse effect of sotalol or beta-pace, because sotalol causes edema of the extremities of the hands and of the face. And when this occurs, you need to refer it to the healthcare provider. So once again, this is your mentor Ray saying thank you so much for joining me today. And this is an opportunity for you to get a peep into the contents of my latest book. Okay, thank you so much. But wait, we're announcing the winners. Okay, so thank you for those who joined us today. Okay, and be a USRN, so you can text or call us and join our thousands of USRNs who are now in the US. Okay, and of course, you're invited to subscribe our YouTube channel. We are now more than 12,000 subscribers. We just started not so long ago, and we're so overwhelmed with the feedback. Okay, and this is our YouTube channel. We are now more than 12,000. Okay, so thank you very much. And here we go. Here are the winners. View your name. If you are one of them, send us an email right away. Yan na. Palakpakan na natin. Yung bang kanina, paano yun yung na-record mo nasa gitna na? O na-record magmula